Hello, welcome to Garden House Hospice Care Dying Matters Week, Advanced Care Planning Questions and Answers. Over the past week, many of you have been sending in your questions for myself and my colleagues about advanced care planning. And so today we're going to try and address these questions. My name is Dr. Ros Marvin. I'm a consultant at Garden House Hospice Care.
Hello, and I'm Dr. Sarah Bell. I'm the Medical Director and Consultant at Garden House Hospice Care, working with Ros.
So Sarah, we've had a number of great questions about advanced care planning, so we won't be able to cover them all individually, but would you mind starting by explaining what advanced care planning means, what can be planned and why, and how people should go about it?
So advanced care planning, it can seem like a slightly strange title, but at its most basic, it's a way for people to say what their wishes are for in the future, particularly thinking about times when they might not be able to speak for themselves, if they were confused or just not able to express their own wishes for any reason. So advanced care planning covers a whole range of things. It includes where you would like to be cared for in the last year of life if you became poorly. It includes where you would like to be at the very end of life when you die. But it also covers a whole load of other things, such as perhaps making a will, thinking about what you might want in the last period of your life, who you would want to see, who you'd want to be with. It includes things such as consideration for making a lasting power of attorney arrangement or an advanced decision to refuse treatment. It also includes things such as do not resuscitate orders, treatment escalation plans, tissue donation, and possibly even making a digital will, but a whole host of other things.
Thank you. Someone has actually asked how much time does it take to do advanced care planning, but I suspect the answer is that it's not something that's done in one go, is it? It's a process that takes place over time.
That's right, and actually it's one of the really important things that we really want to promote about advanced care planning is that it's for everyone who is involved to take part in. So for example, some people will feel actually, say they go to see their GP, the poor old overworked GPs only have 10 minutes, and maybe they would feel that this isn't something they could get involved with, but we would actually say that every healthcare professional involved with the patient and their family could do one thing on this pathway. And it's so important because actually we know, and there's backed by evidence, that people who have been involved in advanced care planning actually have a better death and are far more likely to die and be cared for in the places they're choosing. So there's ever so many good reasons to get involved.
Absolutely. And I suspect as well that one of the most important things is to, if you have some plans for the future, to share them with your family, because it's only if they know what plans you've made or they know where certain documents are kept, for example, that they would be able to access them if you were unable to do so yourself.
Absolutely. Communication is the absolutely key thing here. And what we find, and I know, Ros, that you've experienced this too, is that it can be quite difficult and potentially upsetting to have some of these conversations. But actually, time and time again, I have people come and we have this conversation in clinic and they come back maybe the next week and they're walking about a foot taller because they're so happy that actually they've arranged all these things, that everybody knows what their wishes are and they've got these things out in the open. You know, the old adage, a trouble shared. So yeah, we'd really encourage people. It really is a great benefit.
Absolutely, and certainly some of the most distressed patients I've cared for on the inpatient unit are those who've been sadly unable to make plans for their families. For example, they haven't been able to make a will in time, and that does cause a lot of distress at patients when they're at the end of life.
Absolutely.
Talking about wills and funerals and things, we've had a number of questions, first of all, on funerals. So somebody's asking, when should I plan my funeral? And another question is, how much do funerals cost?
So both really great questions. So it's a little bit how long is a piece of string, how much your funeral costs, because of course it depends on what kind of funeral you have. But the average UK funeral is about £4,000, but of course could be considerably more than that. When should you plan your funeral? I think that's really up to the individual, but actually it depends a little bit on how you see a funeral. So some people may see a funeral as something that they very much want to impact. It's something that has to be woven through with the threads of what they would have wanted, and others will see it as something for those who are left behind. So it's much more important for those who are left behind to make the choices in regards to the funeral. But the key thing is, however you see it, if you want to be involved, discuss it early, because as you just said, Ros, that really does lead to peace of mind.
Absolutely. And I think there's two aspects as well to planning a funeral. There's the financial side of things. So if you know, for example, that there might be issues with finances, then there are ways to put in place, you can put money towards funerals in advance. But then, of course, as you've been saying, Sarah, there's the wishes of how the funeral itself would go in terms of, burial or cremation or a woodland funeral. There's all sorts of personal wishes, as you say, that need to be taken into account potentially.
Absolutely.
Thank you. So coming on to the next set of questions, people have been asking about wills and inheritance, and this does seem to be a sort of a theme that people are quite concerned about, actually. So the first question would be, who would inherit if I don't have a will?
So I am just going to look up, which I can't now find my notes, but because it's a legal situation to die, as the term is intestate, we just want to make it clear that we're obviously, Ros and I are both consultants in medicine, we're not lawyers. So what we've done is looked up some information on the internet, and the information I'm about to read us is from the Citizens Advice Bureau. There's also good information from YouGov, and we would encourage people to look this up and make sure that they check the circumstances for their own situation. So Citizens Advice says, if there are surviving children, grandchildren or great-grandchildren of the person who died, and the estate is valued at more than £270,000, the partner will inherit all the personal property and belongings, the first £270,000 of the estate, and half of the remaining estate. If there are no surviving children, grandchildren, or great-grandchildren, the partner will inherit all the personal properties and belongings and the whole of the estate with interest from the date of death. But I just cannot emphasize enough that this is definitely a legal thing, that we would encourage people to seek actual individual legal advice.
Absolutely, especially as I think there's a difference between partners who are married or in a civil partnership versus people who are simply cohabiting, who might feel that they are common law partners, but that term doesn't mean anything legally, is my understanding at least.
You're absolutely right. Unfortunately, that has no legal standing. So one of the things that Garden House Hospice is doing is that we have our Make a Will scheme. And if you go onto our website, you can find out more details. But this is a way by which you can make a will through partner solicitors, and you can give a donation to the hospice, but you don't pay for the making of the will. And it costs usually a few £100s for a will to be made in this country. So it will be a great way to support the hospice and make sure that you have your will in place. And it's certainly something that that my husband and I have taken advantage of.
Yeah, absolutely. I think the real importance is to realise that there may be issues if you don't have a will. So the best thing to do is just get on and make one, and making it through the hospice is a brilliant way. Another question that's come up that highlights that there are issues if you don't have a will is, what happens to a pet if I die without making a plan for their care?
Good question. So if you have a pet and you die with a will in which there is mention of how you want the pet to be cared for, that's the best situation. Actually, if you've nominated a person in your will to look after your pet, the person isn't legally obliged to do that, but it's a good start for the executors to go. That's the first place the executors of the will go to. If that person, say their circumstances has changed since the will was made and they no longer feel able to take on the care of the pet, the executors are then responsible for the care of that pet. That doesn't mean that they necessarily personally have to take on the care of the pet, but they have to find a solution. If you die without a will, it will be on a case-by-case basis. And it will be a situation of trying to find somebody that would look after the animal, or the animal being taken to a shelter. And obviously that would really be best avoided if at all possible.
Thank you. There's another question that is linked, I think, to wills, which is, if I am not married, who is considered my next of kin? And that's quite a complicated question, actually. It sounds simple, but it's not as straightforward as it sounds, is it?
Well, next of kin doesn't actually, again, have any legal standing in this country, in the UK. So there's therefore no requirement for the next of kin to be a blood relative or a spouse. It could be a friend, and indeed we do see that, not infrequently. The person who is nominated as your next of kin must agree. Sounds obvious, but actually always worth checking. And the status of next of kin actually confers no legal rights or responsibility. So it doesn't mean anything in terms of inheriting money or property, doesn't have any other implications, except there are a few exceptions to this under the Mental Health Act, but for our purposes there aren't. And it really is a way for this being the first port of call for communication with healthcare. And also, if the patient was to not be able to speak for themselves, the next of kin might be the first person that healthcare professionals would talk to find out what the patient's wishes would have been if they had been able to speak for themselves.
That's right. So it's about the patient's wishes being found out, but it's not about the next of kin making decisions on their behalf, unless, of course, I suppose they have a lasting power of attorney, which we might come on to.
Well, actually, I think that's a really good point, Ros, and thank you so much for bringing it up. So let's just quickly cover lasting power of attorney. So lasting power of attorney has replaced enduring power of attorney. Existing enduring power of attorneys are still valid, but we now have lasting power of attorney, two kinds: health and welfare, property and finance. So for health and welfare, which is the kind that most commonly affects us in our working lives with our patients, the patient will, or the person will nominate an attorney or attorneys as part of the lasting power of attorney process, and they will also need to nominate whether they can act on their own or in conjunction with other attorneys, and they need to make the decision as to whether they can make life or death decisions on their behalf. It then has to be, you fill in a form through YouGov, and it has to ultimately be witnessed and has to then be registered with the Office of the Public Guardian, which does cost, although there are some reductions for people who are in receipt of benefits. The point of having a lasting power of attorney for health and welfare is that if you were to lose the ability to speak for yourself, so we would say that to lose capacity, that means either be, say, for example, too confused to speak to yourself or not actually able to express your wishes, your attorney or attorneys would speak on your behalf. It's very similar for property and finance. The main key difference, obviously, is that an attorney for property and finance is only in relation to property and finance, and you can nominate your attorney for property and finance to start to act on your behalf before you have lost capacity, whereas for health and welfare, they can legally only act on your behalf once you have lost capacity, once you're no longer able to speak for yourself.
I think that's a really especially important point, isn't it, Sarah? So if it's likely that someone's going to lose capacity in the future, if they want an LPA, they need to do it before they lose capacity, because partly it takes a few weeks to go through, but also you can't appoint an LPA for a patient who has already lost the ability to speak for themselves. So it has to be done while the patient is clearly able to think and communicate.
Absolutely, and actually at the minute, so many people have become aware of the importance of LPAs, that's lasting power of attorneys, with the COVID pandemic. There's now several weeks delay once for the process to be completed and registered with the Office of the Public Guardian.
Absolutely. So moving on then, one of the major decisions to be made as part of advanced care planning is about resuscitation. And we've had a question about the decisions behind this, but I wondered first of all if we should maybe talk about what resuscitation is and what resuscitation means before we get on to the sort of decision-making process.
Go ahead, Ross.
Thank you. So when doctors and medical healthcare professionals talk about resuscitation, what they are talking about is that when a patient has reached a point in their illness where their heart and their lungs are no longer functioning, their heart has stopped beating and their lungs have stopped breathing, if a patient it reaches that stage and they're actually officially dead, resuscitation means making attempts to bring them back to life. Now, that might be with what's called basic life support, so chest compressions and mouth-to-mouth resuscitation, so breathing into their mouth. It might also involve the use of a defibrillator to give electric shocks to force their heart to restart. And it might also involve, if they were in hospital, for example, giving drugs like adrenaline to try and force the body to start up again. Now, resuscitation can be successful. You see it on TV a lot. It can be successful if the patient has died very suddenly and they might have a single cause of death, like a sudden blockage of an artery supplying their heart, but the rest of their body is healthy. And if they're successfully recovered, they may expect to have a reasonable quality of life afterwards. However, many of the patients that we see who are frail and have serious illnesses do not have a cause of death that is one sudden onset thing. It might be that many of their organs are failing, and this makes trying to bring them back to life after they've died incredibly unlikely to be successful. So when we talk about resuscitation and not attempting resuscitation, what we're talking about is that we would fill in a form that would allow a patient to die a natural death, rather than having healthcare professionals or bystanders attempting to revive them back to life, which we know has the tiniest chance of success in the majority of our patients. So one of the questions that has been asked is, are doctors allowed to give an opinion on whether to resuscitate a patient or not? It feels like a huge decision for the family to make alone, says the questioner.
So that's a really good question, and actually let us be really reassuring that the patient and the family are not expected or requested or required to make that decision. It is a medical or a nursing decision of senior nurses or doctors who are sufficiently experienced to be able to make that decision. However, while the decision to make somebody not for resuscitation, as you so nicely said, Ros, to allow them to die a peaceful and dignified death from the underlying health condition, while that lies with us as professionals, we should always be consulting with patients and relatives to ensure they understand what's happening and to seek their input and to understand their wishes.
Absolutely. And I think if it was medical treatments like, for example, chemotherapy, doctors are only obliged to give treatments that are going to be beneficial to the patient. And it's similar with resuscitation. If we felt it was going to be of benefit to the patient, then we would be in support of it. But if we felt it would deny them a natural death and that actually it would lead to an undignified and unsuccessful attempt at resuscitation, then it shouldn't be something that we are offering as a treatment almost.
Yeah.
So we've had a related question to this, which is, do you have to sign a DNAR, so a do not attempt resuscitation form, even if you have a lasting power of attorney in place?
So that's another really good question. So just let me remind again that it's not the patient or their relatives who sign the do not resuscitate form, it's the healthcare professionals. And that's still the lasting power of attorney is in that process, you nominate someone to speak on your behalf. So it makes no difference to the do not resuscitate order. That's still a healthcare professional's decision, but the attorney would speak on your behalf and express what your wishes would normally be in other circumstances. So the attorney would be consulted when completing the form, it wouldn't be asked to sign the form in any way.
Absolutely. And I think it's also worth remembering that if, for example, you were in your home and you were found to have died, then the decision to resuscitate or not by whoever finds the person needs to be made at that time. They haven't got time to phone around to speak to a lasting power of attorney. Either they attempt to resuscitate the patient, which, as we've talked about, is unlikely to be successful in the majority of our patients, or they know that there's a form in place saying this patient should be allowed a peaceful natural death.
Yeah.
Okay, so talking about death, we've had some questions relating to dying itself. And one question wonders, what would you call a good death?
So that's a lovely question. And I think it depends very, very much on each individual, what they want. But I think most of us would agree that a good death would be one free from pain, free from suffering, in a peaceful environment, assuming that's what you want. I recognise that some people might want a lot of noise and a party atmosphere around them. But the key thing is an avoidance of suffering, and making sure that it ticks all the boxes as much as possible of what that person would have wanted in their last few days and hours of life.
Absolutely. And that's the meaning of palliative care, actually, isn't it? I think the relief of suffering and allowing a patient to live to their fullest ability before they reach the very end of their life and die.
Yes.
So the next question is, what is the number one thing you'd recommend to a person and his or her family who is facing imminent death?
I think the key thing is to talk to each other. And we see it again and again that families who love each other deeply are protecting each other and are not wanting to talk to each other. So they say to us, well, don't tell this to the other one, and don't share this information. And actually what we see is families just not able to communicate properly because for very understandable reasons, they're not able to talk openly about death and dying. And I've seen that with my own family at times, so I completely understand it. But actually, we know that when families are able to talk openly, the relief it brings is enormous.
Absolutely. And in our hospice, we have our family support team who can go in and they can speak to inpatients and help families resolve that kind of issue. And they also do counselling outside in the community. We also have spiritual care volunteers at the hospice. So if a patient is experiencing sort of spiritual distress, we have volunteers who can go in and help them. And of course, we also allow patients to access their own spiritual leaders if they're hospice inpatients. So we really are used to seeing patients at the end of life who have distress of all kinds, and we do our best to help them manage it and hopefully alleviate it.
Yes, indeed.
Thank you. So the final question that we've been sent, Sarah, is do you think that assisted euthanasia will ever become legal in the UK?
So that's a good question, and I think I don't have a crystal ball to answer that one. The hospice is neutral on this topic, but what I can say just purely as an observation is that, of course, over the course of my career, I've had a number of patients who have asked me for euthanasia, and what we do is we'll always address the symptom needs that they have. And time again, I have people coming back to me and saying, I am so glad that we don't have euthanasia, because actually I feel so much better now and I'm looking forward to making the most of the rest of my life. And in saying that, I'm not saying that I'm not making a policy statement pro or against. What I'm saying is actually what many people have said is that actually, I think before we address euthanasia, the most important thing is to make sure we have really good palliative care for all, because actually that's the key thing, is to address suffering and make sure that people are as comfortable as possible.
That's a brilliant point, Sarah. I absolutely agree. Thank you so much.
There's just a couple of things that perhaps we haven't addressed that I'm hold my hand up that I haven't addressed, and I just quickly bring them up. One of them is treatment escalation plans, that particularly during COVID, there was a recognition that we didn't want to have people going into hospital. I'm not just talking about hospice, I'm talking about the whole of the healthcare system, that we wanted to avoid unnecessary admissions. So for people, we would talk through treatment escalation plans, and these ask a number of questions about what would and wouldn't be suitable for them. For example, things like, would they be suitable for ventilation? Would they be suitable for intravenous drugs, etc., etc. So that's something that a patient or family may encounter as part of or linked to a resuscitation order. It allows us to make sure that the care we give is appropriate, and that we're not trying to do things that would be inappropriate or upsetting or distressing to people without having thought it through. And the other thing I just quickly wanted to bring up was an advanced decision to refuse treatment, which I referred to early on. And that's in a very specific set of circumstances where a patient might, or a person might wish to say specifically, I don't want to have that particular treatment. Now, actually, an advanced decision can be verbal if it's not pertaining to life and death treatments, but where it pertains to treatments that could be regarded as life or death, it does need to be written down, witnessed, and signed and dated. That's a very brief skim on that topic, but I just wanted to make sure that I hadn't left people wondering what this was. Thank you, Ros.
Thank you so much. No, thank you for bringing those up at the end. They're very important. But it's been lovely to chat today. I hope we answered the majority of questions. And yeah, I'm glad that we could chat today. Thank you.